I'm up. So I was sorely tempted to take the prerogative of being up next to step up and start asking more questions. So maybe in some of the things that I'll talk about, Richard, you'll feel free to weigh in some more on this. We want to take some time to reflect on the themes that are emerging out of the conversation today to help us inform where do we continue going with this dialogue. And in a couple of minutes, we're going to break, and people together should take some time to discuss what they're hearing, where we think we should go, how we're doing in this conversation so far. I do want to reflect on a couple of things Dr. Frank said, because I think there's a lot of importance in there. And I actually really enjoyed the way you started your reflection and ended your reflection, because I think you came full circle around to a key problem that we have, and it relates to engagement and the difficulty, the relative ease or challenges of engaging people, and then in the end, the problems of a more automated, a less personal engaged society that we're moving to, which in some respects provides great economic benefit to us, and at the same time creates a bunch of risks. So, hopefully in the time before the flying killer robots, we live as their underlings. We will figure out to get the right balance between the technology and people. But one piece of this, and you touched on this in terms of the workforce, and this is, I think, still an open question in my mind, because when I really started trying to drill into this subject, one of the basic things as a history major instead of an economist was, okay, how many people need services and how many people are there to provide those services? Just the basic, simple way of looking at it. And the closest thing that I could find to scaling those things was some work that Richard Laird and David Clark had done studying the National Health Service in the UK. I miraculously picked up a book at Daunt Books in London, world's greatest bookstore, picked up the Thrive book. I said, hey, Thrive, Kaiser Thrive. Oh, wait, this is Mental Health Thrive. But it's actually a fantastic book. It goes into a lot about applying new technologies, applying cognitive behavioral therapy more broadly across the population as one option. But they made the point, too, that there really is a disconnect between the benefits that can be gained by getting people the support that they need and the relative lack of personnel to lead people through that. And then when I looked at the United States, really all I was able to find was the work that you had done, which was great work. I enjoyed the book, and your Niebuhr paper was also excellent. And the points that you had made in that space was we've come from a place, much as your point about being ahistorical, where we have a much larger number of practitioners able to provide services, maybe 20 to 15 years ago than we had 30 to 40 years ago. And then the question was, looking forward from now until 20 years from now, are we on the same trend, or are we going to run into some problems? And it struck me that, as we within Kaiser Permanente have been beefing up our capacity, and on the other hand, draining much of society of many of its, clinical staff, there is a need for much more intensive training. And your point, I thought, was very important, which was as the money becomes available to do this, the economist's view is if you put the money there, then things will change and people will flow into that. Leaves open the question, what kinds of training, what kinds of people, how do we open up those, how do we go upstream to start the policy change we need to change in order to enable that shift? But I thought you sort of encapsulated all of that in some respects in your commentary, and for me that captures what I think is a piece of what we should be talking about, is how do we create a political and health economy that enables us to understand the need that's in front of us and then begin executing toward meeting that need down the road. And there's about 20 things inside that space that we're going to need to figure out how to drill into, which is going to involve which types. I think there was a great comment on scope of practice and the energy that goes into who gets to do what, as opposed to the problem of an order of magnitude too few people to provide those services to start with. So, but I think many of those issues did get surfaced today, and certainly capturing it, bringing people together to talk about it some more is quite crucial. So I think we were also, Ceci, going to put a slide up of the various things that we'd talked about that bubbled up in the little electronic popcorn session that came up earlier. Now, Doreen did make a comment to me that she had sought to put drug abuse or substance abuse disorders into this list, and it bounced out of the system. So we're going to have to test this system to see if the bouncing of substance abuse and drug abuse isn't in there. But that should be on the list as well. And I would note, I do think we had quite a robust discussion in the substance abuse space, which I think was excellent. Maybe that was the problem. But so, you know, I'm just throwing it out to the group. How do we think we did? Do you want to take on this discussion?
No, it's a good question. I think we actually wanted to pull another question as well.
Pull away.
But actually, thank you for raising the question. As folks remember, we had a number of ideas listed in the question about what you'd like to learn about today. This is just a snapshot of some of the responses that we got. But I do think we hit on very many of them. We had a pretty robust conversation about opioids. We had some work on workforce. I think the role of schools came up, which is something that I think we need to continue to think about as well. But many of these, I think we have hit on quite a bit. So I'm going to turn us to our poll question for now, which would be to please give us some information about what you would like to talk to in the future. What are the issues that we either addressed here but you'd like to learn more about, or what are issues that we just never got a chance to talk about? So for folks that are new to us, there's information on each of your desks on a tent around how to submit your responses to the poll question. You can text, so text KP IHP to 37607 if you are joining us new and don't have the capacity yet. And then I'd love to see what comes up. So more on workforce strategies, great. Children's behavioral health. Excellent. Patient engagement, wonderful. Early intervention, best practices treating opioid addiction. Clinic to community integration, great one. Increase engagement, yep. Customization for children. Payment models. Scope of practice, that's a whole week. That's a whole week session. Workforce and technology. Solutions for how to address problems brought up today. Yeah. Best payment models for services for mentally ill. Foster resilience. Role of social determinants, great. Intersection of mental health and criminal justice systems, great. Engaging the business community. Wonderful. Thank you. We do have the capacity to keep record of what was shared with us today, so we'll continue to go back to these notes. So thank you for continuing to send your responses. I'll pass it back to Tony now.
Okay.
Thanks.
So apparently we're doing extraordinarily well on time, which means that there's, I think, opportunity for us to have a little bit more open discussion, even as we perhaps break for some more small group discussion. So I do want to just open it up for other thoughts that people have so far today and what they've seen. So please.
So I'm customization for children again, and I brought some data with me. We had a lot of discussion about whole health populations. and resiliency and recovery. And the great thing about kids is they get better, but they don't get better unless we give them treatment. And when it comes to children's systems, in looking at their whole healthcare costs, behavioral health costs of the driver, services of the healthcare cost drivers, not physical healthcare. So there was just a study done by the Center for Healthcare Strategies and Human Services Collaborative, nodding over there Medicaid Max data, looking at from 2005 to 2011. In 2011, of the 32 million children enrolled in Medicaid, about 1 in 10 used behavioral health services and/or psychotropic medication. And those children represented 36% of the cost of all children in Medicaid. If we talk more about those children, they cost 4 times more than children in general in Medicaid. And when we look at the SSI disabled population, 8 times more. Then we also talked about psychotropic medications. We look at the kids that are using psychotropic medications, nearly 0.5% are not also receiving a behavioral health service with those medications. And then while 8% of the children receiving medications right now, psychotropic medications are ages 0 to 8 years old. I'm sorry, 0 to 5 years old. And since 2005, that's increased by 130%. So there's a lot of data out there about kids, and this really, really, really makes the case for customization for children. So how about another policy institute in kids?
Okay.
Thanks.
That's a great suggestion. I'm looking at my colleague Don Mordecai in case he wants to comment on any of these things as they come up, but not necessarily, not a mandate, not a mandate. Yep, please.
Hi, this is sort of a logistical question, but I know my main points of follow-up are people that I want to reach out to or follow up with from here. Is there going to be a participant list or contact information or follow-up materials or any of that kind of stuff?
Yes, we can make that. Yes, we can make that available. Yes, to folks who registered for today. So if you haven't registered for today, please make sure that you go to the back table and give us your contact information. But we can certainly share the folks who were able to join us today.
And if someone does not want their contact information shared, let us know.
That's true too. If you do not want your contact information shared, please go ahead and let us know as well, and we'll take you off that list. Thank you.
Professor Frank.
Yeah, I guess it is. I just realized there was one thing that I didn't get to in my notes because I was trying to be polite. So, on the opioids crisis, you know, it was actually very reassuring that more or less things that happened in the previous administration are largely carrying through. But I did want to remind people of one thing is that as we do our happy dance around the Cures Act, which is $1 billion over 2 years, that money and every other dollar that we spend on opioid is dwarfed by what we spend in Medicaid on opioid overdose reversal and treatment. And just to give you a feeling of the magnitude, the state of Ohio is getting about $61 million from the Cures Act. Last year, they spent $238 million on the Medicaid expansion only. I'm not talking about traditional Medicaid, but the Medicaid expansion only on people with opioid use disorder. So we're talking like orders of magnitude differences. So, you know, we need to kind of keep our policies like aligned and consistent.
Are there big gaps that we can actually start? I mean, obviously the attention on opioid addiction is huge now, and the problem is massive, and it's caught in between this, you know, essentially judicial process and a health process. Are there things that we should be encouraging to fill in that gap?
Yeah, and you know, this is I'm a little reluctant to dive into the culture wars, but this is actually a place where the culture of wars kind of kill people, and so I sort of step in here. When a court says we will not allow people to get medication-assisted treatment for an opioid addiction, that's not necessarily a good thing, because many of the people involved are probably open to it and may not wind up getting much of anything otherwise. And so I think that kind of being a little bit more eclectic, if you will, requiring the courts to be at least eclectic in offer might be a reasonable thing, or at least creating incentives for them to be that way.
It's helpful. Any other thoughts before we break into some small groups to continue this conversation? I don't know, Pete, if you had more thoughts to reflect on while you've been here, listening to other folks talk. You were super compelling, but does this feel like it's moving in the right direction? Get you, Mike. There you go.
And that most people, I think, do have a chance to recover, and most people do get better. I think the conversation that is always the most difficult is it's all about money. I mean, I'm sorry, folks, that's what it's about. And you either incentivize people with money or you punish people the other way. And so I think with this administration, what I'm hearing is there's plenty of money out there. We just need to reprioritize how we're spending it. And I'm not quite sure how that's going to shake out. As a journalist, I'm very curious about how we're going to do that. But I think that that's basically what I'm hearing from my Washington sources is we're going to cut as much as we can, and then we'll shift to what really works, which sounds great, but I'm not quite sure exactly how that's going to end up affecting all of us. So thank you.
Thanks. That's helpful. Okay. So why don't we, I should hold this back here so it doesn't confuse the folks. So why don't we take a few minutes to break for small discussion within whatever group of people you're sitting with or would like to be sitting with. And we've asked the Kaiser Permanente team to come find you if you're not actually discussing things and make you discuss them with each other. But we'll do that for maybe 10 minutes, come back, do just a little bit of sharing of any thoughts that emerged there, and then we'll prepare to wrap up for the day.